Dr. Ung. Here, just use the mic.
So in an hem-onc in an ID is very limited. However, neutropenic fever is frequent, limited but frequent. So, and the board question-wise, you may say so, is probably perhaps one question from the hem-onc in the ID aspect will expect that. However, every day-to-day basis in the inpatient service, neutropenic fever is almost unavoidable for you guys if it is not inpatient in the ER wise also. So I think all residents need to understand it about the neutropenic fever management there. So this is the one and only questions and the MACSIP there. 37-year-old women evaluated for emergency department fever, rigors for 4 hours duration, medical history significant for acute lymphoblastic leukemia, for which she completed multi-agent chemotherapy 10 days ago. Her medical history is otherwise non-contributory. She takes no other medicine. On exam, 101.8 temperature, stable BP, pulse rate 100, lungs clear, remainder of the physical exam is unremarkable. Lab shows total WBC is 0.3, which means neutrophil is 0. Remaining lab studies are normal. Chest X-ray is normal. Blood and urine cultures are obtained. Which of the following is the most appropriate next step in management? You know neutrophil count is 0. Will you be giving a GCSF? Await culture results before starting antimicrobial therapy. Begin piperacillin, tazobactam, or begin vancomycin. So, Chief Resident? Right. So, yes, we can think of a culture. Of course, probably we already did the cultures. I will not say probably you have to do cultures right away, but, you know, right away you tell the nurse, this patient needs CBC, the antibiotics to start it. If patient wait until upstairs is not appropriate, while the patient is in ER, administer the antibiotics quickly, please, all right? Vancomycin, you will not do the vancomycin unless you have some sound reason to choose this vancomycin. So I will go for, you know, future questions there. So sometimes my nurses will ask me, do you want to give the GCSF things there? Yeah, you could, but once you have a bottom-down bone marrow, you can't stimulate it. You got to wait there. So yes, in the inpatient, we always started it there. It's not, you know, completely wrong, but you're not going to be effectively seeing it. So antibiotics is the first response that you have to do it. So infectious complications in the neutropenic are febrile neutropenia, just the fever alone. Some people presented with pneumonia, catheter-associated infection, and GI infection. So for these 4 things you see, febrile neutropenia, this patient has nothing else other than fever. That's it. So the question is, when do you call that this patient has a fever? Commonly, sometimes the nurses will call you, oh, patient has 99.8 degree, thinks that she's having a fever. So there we go, 54-year-old, stage 4 DLBCL, diffuse large cell fever, chills, 9 days after receiving his 3rd cycle of R-CHOP. Which of the following as the IDSA definition of fever in a patient with severe neutropenia? So oral single temperature 38, oral single 38.3, or 38 for more than 1 hour, or oral temperature 38 for more than 1 hour, oral 37 for any duration. So we know number 4 is out. So among the 1, 2, 3, which one will be the correct one? The second, Chief, sir? Sorry. Right. So the reason is sometimes, you know, we got phone call. I mean, this hospital, we don't get phone call from the patient. If you are in the private there, they call, right? If you work at the Sloan Kettering, the patient call you, the fellow has to answer it. What's your temperature? The patient will say, I got the 38.3 degrees centigrade. They may usually tell you it's like 101 or 100 things there. Then you know this is a febrile neutropenia. But patient said, I got 100, you know, but I just have a coffee thing there. So you tell them that, can you call call me back or give me your phone number 1 hour later, check your temperature again, and then we'll see it there. Because sometimes temperature is just a transient rise up. So 38 degree for more than 1 hour is necessary. So the next hour when you check it, temperature comes down, you don't have to worry. So single temperature 38.301 or 38 degree for 100.4 for more than 1 hour is the definition of the the fever. Neutropenia is like, yesterday I got a consultation from the upstairs for the Hodgkin's lymphoma treated patient who is in the psych unit there, and ANC of 900. I don't call it neutropenia. I said, well, in our terms, he's okay, not neutropenia. So as long as it is above 500, we're okay. Yes, you can call it leukopenia, but neutropenia is, has to be lower than 500 there. Sometimes you see that 900, the same patient, but you are seeing decreasing anticipation there. So this patient in and out of the hospital for the last 7 months, the same 900 there, then, this is what he is from the post-treatment bone marrow suppression. So the greatest risk is ANC of less than 100. So I hope everybody knows how to calculate it. Our hospital is good that ANC already calculated. Sometimes some hospitals did not calculate it. They only have a neutrophil percentage there. So if you have a neutrophil percentage and then you have a SAGS also was written out there, you can all combine it and then you got calculated by yourself there. Now, the greatest risk is less than 100 and rapid decrease in the count, protracted neutropenia more than 7 days, and some people with abnormalities in their phagocytic function there. So the second question is, the 57-year-old man presents with the clinic with 38.6. 10 days ago, he received chemo for extensive stage small cell lung cancer. Exam reveals well-appearing man with no physical abnormality except fever. Blood cultures were sent. Chest X-ray has no infiltrate. CBC, WBC of 1200. Crit of 31, platelet 101, and neutrophil of 30%. So 30% of WBC 1200 is neutrophil total is how much it is? 360. What is the most appropriate therapy for this patient? He has a temperature already, so start GCSF, antibiotics, start GCSF, no intervention. So which one will choose that? Start the antibiotics. Right. So we don't necessarily want to have a GCSF to add it there. But, most of us are overly doing it there. And by the time that I see the patient consult there, resident already started the GCSF there.
There aren't that many guidelines.
Right. So these GCSF guidelines are in our side there. When we give a treatment, we expect this patient is going to be deep down. Like our chart things there. Day 2, we already give them a Neupogen here. So by the time that patients goes in their hospitals, there is no guidelines. You're on your own. So the only one guidelines come is the pharmacy guideline. Then if the pharmacy is restricting your order, then we become involved in it. Right. So I would pass these etiology, bacteria, because this is really the ID area. Aerobic gram-negative and gram-positives, all those are involved. Fungi are rare. Viruses are very rare. Even though one of Dr. D's patient has a CMV, skin infection things there. So if you are immune suppressed and give the chemotherapy, which is also can immune suppress, you can have a CMV reactivation. So the most important part is signs and symptoms. The problem is lack of physical findings, especially accompanied by the anemia. They have absence of inflammatory response at the infection site because you don't have a neutrophil count, you don't have an inflammatory response. Fever with or without chills and rigors, diminished or absent induration, erythema, pustulation without typical cellulitis, pulmonary infection without infiltrate, meningitis without pleocytosis in CNS, UTI without pyuria. So you have to expect that you have no neutrophil, you can't make a pus. So complete history is important. So the patient will tell you, you always have to write down and ask them, when was your last chemo was there? So this is important, last chemo administration. So you could expect that when is there coming up time, or is it going, they say, well, I got it on 7 days ago. You accept next 4 more days minimum, the patient is going to be more dipped down. Then that is where I will say, well, should I give a new GCSF now and pump it up things there? Physical exam, skin lesion, exit site, tunnel. So every patient come in, you have these metal port. In our hospital, you only see a metal port. If you are in the major clinical hospital things there, they have the leukemia treated, so their port is not the metal port. They are the Hickman's catheter things there, like your dialysis thing. So Hickman's catheter, you have more prone to get these infections. So you really have to look thoroughly on these port area. So that the tunnel of the right atrial cath, oropharynx, yes, do not forget to open their mouth there, because you can miss the oral mucositis, which is easily treatable by the antifungal agent there, but a lot of us forget to open their mouth. Look for disruption of any mucosal barrier, GI, sinopulmonary, GU, listen to it, their lungs there. So 2 sets of blood culture, one from the peripheral, one from the each port if present. So when you have these Hickman catheter, you have a double lumen, triple lumen things there. Each lumen, you have to, draw the blood there. Then only cultures are, which one is positive. So sometimes 1 lumen only is the problem there. And they have these, specific thing is that if you draw that and then you send it to them, you write it down, this is from the, the catheter that you draw, or the port. Then when you send it the specimen and the result came back culture positive, when you have a culture positive and the next culture, the one that you draw from the blood peripheral, was negative or may not be positive yet. So there may be time between, they will say approximately over 120 minutes more earlier, that if the culture positive from the port, then the other one is delayed, then likelihood is this is the port problem, then the whole body, the bacteremia problem is. Stool exam, C. diff, and other bacteria. Urine cultures, we know that if skin lesions, they aspirate or biopsy. LFTs, chest CT is rarely indicated, but if it indicated, you must have some, understanding of what's going on there. So the next question is 47-year-old male metastatic colon CA treated with systemic chemo. She develops pain on defecation along with her low-grade fever, WBC of 1,000, 20% on neutrophils. Visual inspection reveals a perianal fissure with erythema in duration. What should you do next? So she has a 400 neutrophils counts, not too severe. You will do digital rectal to rule out the rectal abscess, recommend stool softener and sitz baths, broad spectrum antibiotic without anaerobic, or broad spectrum with anaerobic. Of course, you will do anaerobic, right? Because perianal has some erythema in duration there. So you don't want to do digital rectal examination. Yes. You do not want it.
Because you don't want it to disseminate.
Right, right.
Broad spectrum with anaerobic.
Yes.
But what do they need to
Metronidazole.
have the abscess drained?
We give them antibiotics first, and whether they heal or not there, and only when they don't heal, that you get a surgical to, abscess to drain it there.
And in such cases, do you do culture? No, right? No blood culture should be done.
Well, every patient come with a fever, you do the cultures no matter what, right? That's like a routine now. I will not skip the blood cultures there. So at least 50% of the patients who become febrile have established occult infection. At least 20% of patients with ANC less than 100 will have bacteremia. Primary anatomic sites of infections are alimentary site, mucosal damage, or the vascular access devices there. So we don't want to think of the pneumonia first. We think of the alimentary, because the mucosal barriers is the easiest things there. That's why do not forget there. A lot of our patients got mucositis. So, we give the hurricane solution and so on, but this is the site that you don't want to forget about it. So a 56-year-old lady, breast cancer, receives chemotherapy. A week later, she experienced a temperature of 102, WBC 1000 with ANC 200. Indwelling catheter appears normal. Appropriate antibiotic options. And patient came to the ER, so you will be admitting it, I guess. So that's why you have to choose between these 4 drugs there. So, Christina, you want to volunteer since I know your name? Just now, I still call her Dr. Perez, but not. Cefepime alone there, because you know that port situs appears normal, so you won't use the vancomycin. Aminoglycoside, no. Ciprofloxacin, you already have the broad spectrum antibiotic. So if the patient is inpatient, that's what you're going to choose it. If the patient is outside there, this particular patient, if I see this patient in my clinic, I will choose the other antibiotics. What do you think that I will be choosing it? One of the physicians who is with me that time when Naomi was sick, she was 102 temperature, the same thing. She had a breast cancer. She's a young 30-something years old lady. So I just give her 2 antibiotics. As a standard of care for us is to give an augmentin and the Cipro at the same time. All right. So then you judge yourself there. Is this patient stable enough there? Pressure's okay other than the fever. You could just discharge her from your clinic, observe her. All right, you take these antibiotics and go home. So who are the low risk and who are the high risk? As long as your ANC is above 100, you are in the low risk there. As long as you have other problems are not exist also. Chest X-ray normal, you have a LFT renal function normal, you expect neutropenia will be less than 7 days, resolution of neutropenia is expected in less than 10 days, bone marrow recovery you are start seeing, no IV catheter site infection, peak temperature is less than 39, no neurological mental changes, no illness appearance, no abdominal pain, no comorbid complications, in a sense that they call it MASCC score of more than 21. So you want to know what is the MASCC scoring. This is the MASCC scoring, and you have these couple of 8 items there, and then you have these weight of that, and then the same thing that I just mentioned, the burden of febrile neutropenia with no or mild symptoms, no hypotension, no COPD underlying. This is a solid tumor you are treating, not the acute leukemia. You are taking care of it. No dehydration requiring IV hydration. Then outpatient status, age less than 60 years. All of them, you put it together, and if they are less than 21 or more than 21. So this is how you calculate it. If they are more than 21, you're low risk. You are less than 21, you are high risk. Because they already validated, they studied that, they have a positive predictive value of 98.3%, negative predictive value of 86.4%, and they correlated quite well with these criteria. So basically, this is exactly how you are going to monitor that. Patient came into the ER with fever and neutropenia, and is this patient at the low risk? According to that criteria, all right, you are low risk. If the patient is seeing you in my clinic, as I said, oral Cipro and the augmentin that we offered it after the blood draw culture. And if you are in the the inpatient in ER there, most likely because you are inpatient, in order to get reimbursement, you got to give an IV. So that's how I was told in my time there. Am I right? Still right? Not anymore?
Or just for the minor question of reimbursements, if they don't do it by which kind of therapy you what therapy you give, IV or oral, the reimbursement depends on the severity of the illness itself.
I see. Yeah, in the time that I was in my training there, in order to get a proper reimbursement, you have to use the IV things there. So monotherapy, cefepime, ceftazidime, and carbapenem is the choice there. Now, high-risk patients, are they vancomycin needed or vancomycin not needed? And then, so if they are not needed, dual therapy with aminoglycoside and anti-pseudomonal together. And then, of course, every patient you reassess after 3 to 5 days later. So the triple therapy is the other way around there. So you will have these slides there. I will leave it in my the chief residence room. So if you want the slides, take that slide. Feel free to take it. Risk of infection by severity, you could see that ANC 100 is significant. If you have ANC 100, more than 1,000, the risk of infection is on this side there less than 10% in the first week. All right. So it all depends on if the ANC is less than 100, you can see your risk is 30%. The ANC makes a difference. But if you are neutropenic for the last 3 weeks, it doesn't make too much difference anymore. You become similar to whatever your ANC level is. You are in the high risk because you are prolonged neutropenia just the same way we treat it. So this is the same way that this Chicago Journals comes up there. So how we choose the oral versus the IV or febrile. Meta-analysis 15 randomized trials shows mortality rate are similar, treatment failure rates are similar. Adverse reactions are mostly GI. Of course, if you give an augmentin orally, they got diarrhea, right? So commonly, oral group has a GI problem. Oral route is safer and cost-effective for a patient with low risk for mortality. So think of it, if you have a patient now clear that nothing to do with your payment reimbursement there, you know this is a breast cancer patient or the lung cancer patient, looks good, just a fever, you can just safely give an augmentin and a Cipro instead of choosing the big gun and sometimes some even add up the vancomycin. Do we really need to add it up on it there? So this patient, inpatient versus outpatient, meta-analysis, 10 clinical trials, studies for over 1,000, and no significant difference in mortality or treatment response between the two arms. These are low-risk patients. So if you see the low-risk patient, you don't necessarily need to hospitalize this patient. You're comfortable, let them go home, Give them antibiotics, tell them to follow up with our clinic in 1 week or 3 days later, and that will be okay for it there. Readmission rate for outpatient group are 14% due to persistent fever, not life-threatening complications. Outpatient therapy, low-risk group is safe, effective, comparable with the standard hospital-based therapy. All right, the most criteria important is you have to identify, are they low-risk patient or high-risk patient? There is nothing like staying at home for real comfort. See? So let them go home. So practicing oncologists, they study there in the United States, 82% use the outpatient antibiotic management for selected patients with neutropenic fever who were considered to be at low risk. So when I was a fellow, Michigan, 4 hours away, these patients has to come to your clinic there. Of course, they do have their medical primary care physician, but the oncology service 4 hours. So we usually even give them antibiotics in their hand there. This is 2 antibiotics. You may need it in the middle of the night when you have to call us. Then save it in the refrigerator. And if you do have a fever, you talk to us first. Fellow will tell you, here, you take that medicine. So they are safe in their own home rather than middle of the night. We don't have 24 hours CVS pharmacy quick, often in Michigan things is. So here you are okay for it. So afebrile in first 3 to 5 hours, 3 to 5 days later, you find 3 to 5 days later, no etiology is identified. This is a low-risk patient. And if they are already on IV, change it to Cipro, augmentin, and discharge. If you are a high-risk patient, continue the same antibiotics. If you find the etiology, identify, you treat accordingly, according to whatever appropriate antibiotics. Are there factors predictive of early discharge? It is dependent all on the physiological reserve and outpatient status at fever onset there. So the next question is 56-year-old stage 3 non-small cell lung cancer on concurrent chemo-RT, odynophagia, retrosternal chest pain worsened over the past few weeks. ANC is 800. Which of the following causes is the least likely cause of his symptoms? Candida, HIV, CMV, radiation, esophagitis. Anybody want to volunteer? Which of the following causes is the least likely cause of his symptoms? I'm not very good at name there, so CMV is the least likely cause there. Since I mentioned about the other patient CMV, he is a CMV reactivation because his underlying disease and the treatment that we give. And this is the radiation chemo for the non-small cell. His immune system is nothing really wrong with that, all right? So Candida HSV, Candida esophagitis is the most common. Open their mouth and you may see nothing. But because it is right in here, lower part of it there. So radiation esophagitis is very common. I don't know whether you guys know that one of the patients, his name is Iba, who has a lung cancer, late diagnosed, and then sent him for radiation treatment, inpatient to Kings County, came back to my clinic. He has a severe radiation esophagitis. Now, patient is started on appropriate empiric antibiotic, remain clinically stable, but still neutropenic with persistent fever after 4 days. Now you're stuck. This is inpatient. In addition of what agent would be indicated at this time. So after 4 days later, patient is still neutropenic and patient still feverish. Antibiotics are still on board. So you have to choose one of those antifungal agent things there. That is basically any of the above. So fever persists 3 to 5 days. If no etiology found, continue initial antibiotic. If no change in patient's condition, consider stopping vancomycin. So if you already started the vanco, stop the vancomycin and see. Change your antibiotic. If progressive disease, if criteria for vancomycin are met, antifungal drug with or without antibiotic. If febrile through days 5 and 7, resolution of neutropenia is not imminent. So that is the most important. Resolution of neutropenia is not imminent. It's still ongoing. This is rarely you see it in this hospital because we don't treat this kind of acute leukemia. But acute leukemia patients are the one that we ended up giving a antifungal. One of my lovely patients, Hodgkin's lymphoma, he died with a fungal aspergillosis things there. You know, so aspergillosis, how do you get it also? You know, he went to UPenn there because everywhere is now construction goes on there. And you can easily get those things there too. Wear the mask. 61-year-old male, a woman with non-Hodgkin's lymphoma, present with fever, cough, prolonged neutropenia. CT reveals bilateral lung nodules with halo sign. Serum galactomannan assay is positive. What is the most likely cause of agent is? Aspergillus, Pseudomonas, Staph aureus, Zygomycetes. So halo sign and galactomannan assay, it is for Aspergillus. Galactomannan is Aspergillus there. So they said empirical antifungal therapy, 6 trials they look at it, empirical therapy versus no therapy. Empirical antifungal therapy did not decrease the overall mortality significantly, but significantly decreased the invasive fungal infection. Azoles, liposomal ampho, whatever you prefer, that's fine. So 70 years old male, metastatic non-small cell, present with fever and neutropenia a week after the chemo. He is admitted and started on appropriate antibiotic. His fever resolved after the first dose. How long should his antibiotic be continued? That's common that you see it. Should we discontinue immediately until 24, 48 hours after the last fever for a total 7 days until resolution of neutropenia? Now you're looking at me. Now nobody wants to look at me here. Tell me.
7 days?
She has a magic 7 days. Do you agree with that, Dr. Chief? Huh? The most important is what? Again, low risk, high risk, neutropenia. You want to see, is that neutropenia resolved or not resolved there? So until resolution of neutropenia, then she can fight for her own there. You may say 7 days, but she still have an ANC of 300. You're stuck, right? So you want to make sure this patient is going uphill, more than 500 neutrophil counts, then you're okay with that. So until resolution of neutropenia. So duration of antibiotic, febrile by day 3, and the ANC is more than 500 for 2 consecutive days. You can stop antibiotics 48 hours after febrile. ANC is less than 500 by day 7. Initial low risk, clinically well. Stop when febrile 5 to 7 days later. So that is the magic bullet of your 7 days, you will say. But we always really want to see ANC is coming up to 500 there. That is the criteria. High-risk patients, ANC less than 100, and so on there. So this is how the algorithm goes with that things there. Recess, all of them are based on ANC 500, all right? Initial empiric antibiotics, we all know patients' allergy status, renal hepatic function, and it happens to me. My nurse always remember that. All right, here I got an augmentin, take it there, and she was open her mouth, and I was about to, and I said, "Are you allergic to penicillin?" Yes. Oh, all right. So you have to make sure that you do ask these questions there. Just straightforward is no longer straightforward. Monotherapy. What covers, what doesn't cover, so I will just leave those alone because these are really the ID part of it that you will able to find it. Vanco, all right, when do you want to use the Vanco? Initial Vanco indication, clinically obvious catheter-related infections, all right? This is really red hot, or that this is a catheter, you're coming, and then around then is the erythema there. Undergoing intensive chemo, producing substantial mucosal damage, severe mucositis. You open them out, fully loaded with all the mucositis there. Receiving prophylaxis with quinolone. She said, "I already got the the Cipro or the levofloxacin, at home." No known colonization with pneumococci resistant to penicillin and cephalosporin or MRSA. Blood culture positive for gram-positive bacteria before final identification and susceptibility in testing. With hypotension or evidence of cardiovascular impairment, that's the time that you choose the Vanco. So do not choose the Vanco just because this is a neutropenic fever. Randomized controlled trial of antibacterial prophylaxis in patients with neutropenia have shown which of the following. I never like those questions there. Oh, no difference in fever, infection, mortality, decreased episodes of fever, but no difference in infection, mortality, decreased episode of fever and infection, but no difference in mortality rates, decreased episodes of fever and infection, and lower mortality. It's all confusing. You have to know the articles there. Basically, C is the correct one there. They decrease the episode of fever and infection, but there is no difference in mortality rates there. So prevention is always better than cure. Hygienic measures is the hand washing. All right, so if you have a neutropenic patient games there, you don't have to write it down, big things there, wear the mask, and nowadays you don't do that. Hand washing, hand washing, hand washing. And then if you see those patients in the transplant patient or acute leukemia patients, we have to restrict their diet. They cannot eat like the grapes or the strawberries and things there because they cannot be peeled. So you can have the bananas, you can have orange, all right, but nothing that you can peel it and eat it. And the same thing, you can't smell the flowers because the flowers have dusting in it. So you want to make sure they are clean. So we ended up with no fresh flowers in their room, things there, right? So protective environment are controversial, can reduce the rate but not contribute to increased survival and costly. So in the olden days, in our time, we got to wear all those things there. Nowadays is you have a HEPA filter in it, that room, that's all you needed, reverse things there. So antibiotic prophylaxis, who should be treated? So in this hospital, our patient, we don't give them antibiotics prophylaxis other than a few of them, like a myeloma, if we give the bortezomib, that we give a acyclovir preparation, the prophylaxis. But the rest of the things, not like acute leukemia, transplant patient, we do not give any prophylactic antibiotics ahead of time there. Then consider for first cycle treatment in patients with solid tumor who regularly receive regimens that cause severe neutropenia. And if we know it, we give a GCS attempt there. because we don't want to have a quinolone resistance and things there. And the truth of the matter is, if you give a quinolone, there are no survival advantages. You only prevent what? As I said, fever and infection rate, but not mortality rate is. That's what the guidelines say. Antifungal, when we need it, we give. Acyclovir is the one common drugs that we use it in our clinic there. So next question, which of the following would be the most likely result of adding GCSF to the patient's next cycle of chemo? 66-year-old male developed fever and neutropenia 3 times despite dose adjustment while receiving chemotherapy for extensive stage small cell lung cancer. The risk of mortality would be reduced, the chance of remission is increased, the risk of fever and neutropenia would be reduced, adverse effects of therapy will be reduced, no positive effect is likely. So what's the answer is? You're giving a Neupogen. Because the patient already had a neutropenia 3 times before. This time it said, no, I'm not going to be letting this patient to have neutropenia. So you give a Neupogen. Basically, nothing to do with the mortality to be reduced. We just said that, right? And the same thing, antibiotics prophylaxis. So you cannot reduce the mortality, but you can reduce the risk of fever and the neutropenia by giving a Neupogen there. That bottom line is. The other are nothing that, chance of remission has nothing to do with that. No. So use of colony stimulating factor. It can shorten the duration of neutropenia. It doesn't really reduce the measures of the fever-related morbidity is. No study demonstrated increase in infection-related mortality rates. All right. Use our expected long delay. We think that this is going to delay recovery of the marrow. There is no such granulocyte transfusion nowadays there, So the more part is the, splenectomized patient. You see sometimes splenectomy patient. I keep forgetting also. And in Hodgkin's lymphoma, in the olden days, the patient went for splenectomy as a staging. And he should be immunized against which of the following organisms. So if you have a splenectomy patient, please make sure that you did look at their history of vaccination. Streptococcus, pneumonia, Haemophilus influenza, Neisseria meningitis, which one you're going to give them? All of the above there. And it's not only all of the above you finish in one time there. Like strep pneumonia, you have to repeat it again there, all right? I think the only thing that you don't need to repeat is Haemophilus and Neisseria. The pneumonia is every 6 years you got to repeat it. And the best part is before they splenectomize, 2 weeks before they splenectomize, you give them the vaccine. That will be the best, so that they can still fight for themselves, basically. Splenic is not just a splenectomized patient, splenic irradiation patient. Some people just irradiated. Severe GVA, they will be given for against the encapsulated bacteria, and this is the bacteria that we measure, at least 2 weeks prior to splenectomy. One-time reimmunization of pneumococcal 5 years after, and meningococcal for functional asplenic patient who receive conjugated. This is very important. Functional asplenic patients, who are they? Sickle cell patients. So you see that, and don't forget to ask them, did they ever receive the vaccination? And what I usually forget is penicillin is advised as a prophylaxis. Are we keep giving a penicillin things there? Nowadays, we don't usually there, but that's what the recommendation is. All right. I'll skip that. Catheter-associated infection. You have an exit site infection. Make sure, open it close, and take a look at it thoroughly. This is the area that you guys are listening to the chest, lungs in from the back, and the clothes is still on, so you can't see the pore. So make sure you got the port, take a look at it. Tunnel infection, tenderness along. So the port is right here, but the tenderness is here. So you have to go through this area, all right? Septic thrombophlebitis, no local findings, signs of sepsis of venous thrombosis, edema. So basically, it's a clinical examination is very important. Culture, when do you want to remove this catheter? Blood culture from the catheter, positive, peripheral vein, negative. All right. All we said, so is 120 minutes apart things there. You got both cultures positive, but the culture was positive from the catheter that you remove is earlier, 120 minutes earlier than the other cultures that you draw. And then it is indicating that catheter is the source of infection. Coagulase negative, Staph aureus, carini, bacillus, candida, or mycobacterium, or the patient's having a bacteremia, septicemia. So if this is a Staph epidermolysis comes up there, would you like to salvage this? Because this is a skin infection, this is the thing that you want to save it. That's, sometimes our catheter is underneath there, we like to save it. Hickman's catheter, easy, remove, put it back in there, new one. Major C. diff associated diarrhea. And I know we rarely have these patients there, but if you treat an acute leukemia, you're stuck. This patient is going to die. That much sad. Major risk treatment with beta-lactams and clindamycin. Antibiotic therapy disrupt the normal bacterial flora of the colon and allows colonization of C. diff. Spore forming, that I don't have to mention it. Pseudomembranous colitis happen there. So my patient is acute leukemia, pancytopenia, thrombocytopenia, platelet count is 1,000. Nobody will take him to the operating room, and he's having a toxic megacolon and C. diff there. And basically, you just watch him die. So they can be asymptomatic, mild to moderate diarrhea with low abdominal pain, fulminant colitis, we call it toxic megacolon, and perforation of the viscus and peritonitis happen. Occasionally, fever, abdominal pain with no diarrhea. So you don't have to have a diarrhea. 64-year-old male with pancreatic C, diagnosed with C. diff colitis. He's treated with course of oral metronidazole 500 TID, but he continues to have diarrhea and stool C. diff remains positive. What is the most appropriate treatment at this time? Yeah. Everybody knows that, right? Which one you going to choose? 2, oral vancomycin, yes. So it's interesting, right? You know IV metronidazole works. Oral metronidazole works, but the vancomycin has to be only oral. Vanco IV does not work. The dosage is different, IV and the oral metronidazole are. So this is how it goes with oral and the, of course you can always look it up in the up-to-date things there. The newer drug is, I have never used it there, fidaxomicin there, which I never heard of yet. That was the new drug. So relapse are common. Once you get colitis, 10 to 20% relapse, 7 to 14 days course of either metro or vanco is needed. If persists 4 to 6 weeks, followed by gradual tapering of the dose. So colitis not easy, just your home discharge is not right. You have to give them a longer duration there. Contact isolation, everybody know, disinfection, those patients doesn't need antibiotic prophylaxis. So this is the lady with the 34-year-old acute myeloid leukemia, received induction chemo, 10 days later, experienced severe right-sided abdominal pain with nausea, vomiting, diarrhea. Even though we don't treat acute leukemia here, but sometimes we do receive acute leukemia patient, treated somewhere, patient lives around in here, ended up in our hospital. So she has fever 101, tender abdomen without guarding, rebound, ANC was 0. Lactate was normal, stool C. diff assay was negative ×3. What is the most likely diagnosis is? CMV colitis, typhlitis, bowel ischemia, bowel perforation. So this patient doesn't have C. diff. This is called typhlitis. Necrotizing enterocolitis occurs in severely neutropenic patient, involves cecum and the terminal ileum, broad spectrum disease, bowel wall edema, diffuse patchy necrosis involving the whole mucosa involved in it there. You can have bacteria, fungi, but they call it typhlitis. Signs and symptoms are non-specific. Fever, right lower quadrant, abdominal distension, sometimes bloody diarrhea, nausea, vomiting, signs and symptoms of acute appendicitis. abdominal guarding rebound tenderness, diminished bowel sound, or sometimes even mass in the right lower quadrant. Diagnosis, CT will tell you thickened cecum, mass, pericecal fluid, gas within the colon wall. Treatment, mortality from the typhlitis is high, SI is more than 50%. Therapy is controversial, broad spectrum covering both gut aerobes and anaerobes. And resection of bowel is recommended. And those are the patients who platelet count is low. You can't do much of it there. Predictive factors for septic shock and mortality in neutropenic patients. Who you can predict it? If you get a pulmonary infection, you got problem. Bicarb level less than 17 and lactate level more than 3 at the onset of the bacteremia. So this is the studies done there. This is the nursing studies done about 10 years ago. Antibiotic in 30 minutes or less there. And door to fever to patient antibiotic for the pediatric cases there. 20 months monitoring. No patients were transferred, admitted to intensive care unit due to septic shock. So the patient walk into the ER with fever. You know the patient is neutropenic. Within 30 minutes, the nursing can give them antibiotics. And that you save a lot of patients' life there. So can we do it? We're struggling with the reconciliation and things there. So anyway, please tell the nurse that I already ordered the antibiotics. Please hang the antibiotics, and you know patients neutropenia, and that's what you could do it. No remedy is useful unless employed at the right moment. So this is interesting. In UK or the European countries, they have this molecular diagnosis of sepsis by real-time PCR assay versus the blood culture. The process, if you do it with a SeptiFast kit there, turnaround time in 6 hours, you say what you can do the identification of what bugs is growing in this bacteremia there. Same sensitivity. You can even identify the Candida aspergillus in addition to the bacteria. So far not available in the United States yet. So summary, you all know what's the role of risk assessment. So the most important is you should know the risk assessment. You have to understand, distinguish between the high risk and the low risk when you present it with a fever with neutropenia. Then only you know which direction you will be going there. High risk, low risk, I already told you about that, so this is my summary. And what specific tests and culture should be performed, we already know culture. If you have a port, you port 2 areas to culture. What empiric antibiotic therapy is appropriate and in what venue, you know that. So you can choose it because you know low risk, high risk, you are coming up understanding why you are choosing it rather than blindly choosing it. Oh, they are neutropenic patient. Let's start with the aminoglycoside. Let's start with them. And let's start. So 3 antibiotics. Patient doesn't really need it. And that's what it happened. And the next 3 days later, her creatinine is 3 point something there. When and how should antimicrobials be modified during the course of fever and neutropenia? Now you know it too. How long should empirical antibiotic therapy be given? When should the prophylaxis be given and with what agents? What's the role of empiric or preemptive antifungal therapy? That probably doesn't belong in your area. When should antifungal be given with what agents? What's the role of antiviral prophylaxis and what virus infections require? And what's the role of GCSF? How are catheter-related infections diagnosed and managed? And what environmental precautions, hand washing. And the same, the flow chart there. If you go through, thank you.
Any questions for Dr. Ung, either here or from our colleagues in Williamsburg, right? Any questions?
No, thank you.
Okay, any questions here? Okay, so it seems to me, though, that we rarely, even in the hospital, would be giving Neupogen or granulocyte stimulating according to guidelines. Is that correct?
Right.
And vancomycin only for the particular patient?
Yes.
Yes. So those are 2 good learning points, right?
So all the residents, if you want to have these slides
Yes.
there.
Yes, and we taped it, so you're going to be on YouTube, on an unlisted YouTube channel. I'll send you the link. Okay, good. Okay, thank you. That was great. Very good.